I'm Carina Strell. I'm an associate professor at Uppsala University, and I'm happy to guide you through my poster that I'm presenting here at the AACR annual meeting. And the poster is on PD-1, PD-L1 interactions as a superior biomarker for non-small cell lung cancer patients treated with immunotherapy. And in this project, we tested the hypothesis that we believe that the interaction between PD-1 and PD-L1, the direct interaction, is a superior biomarker to predict benefit from immunotherapy in non-small cell lung cancer. Because we believe that only the direct interaction is telling us if the signaling pathway is active or not. And in order to detect the interaction between PD-1 and PD-L1, we used the second generation proximity ligation assay, which is now available through NaVinci Diagnostics at Uppsala University. And we use this assay together with a chromogenic readout. So as you see here in this tissue sample, it's a FFPE tissue, and the red signal indicates the interaction of PD-1 and PD-L1 in a non-small cell lung cancer section. And in order to quantify these interactions, we use a QPath pipeline, which then gives us the number of positive cells per sample. In a first step, we analyzed how the PD-1, PD-L1 interaction relates to the expression of PD-1 and PD-L1 alone. And therefore, we used an early stage non-small cell lung cancer cohort. And as you can see here, we have patients that express both PD-1 and PD-L1, but those patients do not necessarily have an interaction. Actually, only about 50% of those patients that have both proteins also display an interaction, so having an active pathway. In the next step, we analyzed the PD-1, PD-L1 interaction in a panel of different solid tumors. As you see here, we include liver cancer, breast cancer, kidney, lung, and also testis cancer. And we saw really varying level of PD-1, PD-L1 interaction among these different cancer types, with liver and breast having the lowest level, and lung and testis cancer, for example, having the highest levels. And we related the level of the interaction with published reported objective response rates to PD-1 or PD-L1 immunotherapy. And you can appreciate from this figure that there's a certain correlation or association of the PD-1, PD-L1 interaction frequency with the response rate to immunotherapy, except, for example, here glioma and lung cancer in the top, which are usually rather low responders to immunotherapy. And then we have testis cancer, which has very high interaction levels, but interestingly, immunotherapy isn't used for these patients. In the next step then, we analyzed our Uppsala immunotherapy treated non-small cell lung cancer patient cohort. And there in this cohort, we run the assay on pre-treatment biopsies, also again FFPE material. And we performed the best cutoff strategy to find how we can stratify patients in the best way. And we saw that those patients that have a high PLA signal, so high frequency of interactions, those indeed showed a better survival after treatment with PD-1 or PD-L1 inhibiting immunotherapy. As compared here, you see those patients with very low interaction, those showed a worse survival upon immunotherapy. And interestingly also, we had a matching control cohort of lung cancer patients not receiving immunotherapy. And in this cohort, we don't see the separation. There's no significant effect, and if at all, the trend is in the opposite direction. And importantly, also now when we perform a multivariable Cox regression analysis, this signal that we obtain here, it remains significant. So the interaction remains a significant independent predictor of benefit from immunotherapy. So we also performed a formal interaction test between the PLA signal and immunotherapy as treatment, and this also was significant, indicating that the effect that we see is really dependent on treatment and not just on prognosis. And finally, we of course also in the immunotherapy treated patients, we tested the clinical standard, the PD-L1 tumor proportion score with a 1% cutoff as used in Uppsala in the clinical routines. And here we don't see any stratification of the patients. And finally, we also now associated the frequency of PD-1, PD-L1 interactions with the response status of these patients. And as you see here, patients with a complete response have an overall higher level of PD-1, PD-L1 interactions as patients that show stable disease or progressive disease. Here we have rather more low levels of PD-1, PD-L1 interactions. And so to conclude, what we could show that the second generation PLA from Da Vinci is really a very suitable tool to detect PD-1, PD-L1 interactions in diagnostic FFPE tissue samples. And then biologically we could show that PD-1, PD-L1 interactions indeed are associated with a favorable outcome for PD-1 or PD-L1 blocking immunotherapy in non-small cell lung cancer patients. And also our data indicates that this interaction really is a predictive biomarker for immunotherapy response in non-small cell lung cancer, and that it surpasses the clinical standard. So of course we need more validation studies to confirm these findings, and especially the cutoff in other cohorts. And also in the future we like to integrate this PLA assay in our multiplex assay so that we really know which immune cells or tumor cells, where exactly in the tumor do we detect the interaction, that we can better characterize the cells associated with PD-1, PD-L1 interactions. And we have preliminary data here where we could combine the PLA with, for example, CD8 on cytokeratin.